Um, so this is welcome to today's webinar, which is in conversation with civil society, reforming the global health regime. So thank you all for joining us. My name is Samuel, and I'm delighted to be moderating this important conversation. I work with the research team at Civicus, and I'm also part of the Insured project. And before we dive in, let me just briefly introduce the Insured project, which is a research consortium which studies how the EU and its member states can better defend multilateralism and make global governance more robust, effective, and democratic. Its research assesses the state of play in different areas and investigates international actors' strengths and weaknesses with the goal of defending and transforming multilateralism. So as part of this project, we've organized this webinar series, which connects the Insured research, academic research with civil society practice. And we are trying to translate this cutting edge research into practical strategies and concrete guidance for organizations working to reform global governance systems in key policy areas. So this is the second installment of the series, and it focuses on global health governance. So regarding global health governance, the COVID-19 pandemic starkly exposed the different failures of global health governance, and particularly the consequences, the deadly consequences of intellectual property regimes that prioritize profits over global health equity. So by understanding these systemic failures and identifying pathways for reform, we can face these critical issues. And this is especially relevant now as the World Health Organization has recently adopted the pandemic agreement in May 2025, although we'll get into that briefly. We'll get into that into more depth soon. So first, I'll introduce our four panelists. So we have Alexandra Finch, who is a senior associate at the O'Neill Institute for National and Global Health Law at Georgetown University. Her scholarship focuses on global health governance, and she's also the head of the Secretariat for the Panel for a Global Public Health Convention. Nina Jamal is the international head on pandemics and campaign strategies at Paws International, a global animal welfare organization for animals under direct human influence. She has been involved in the pandemic agreement negotiations since their inception. And Jaume Vidal is a senior policy advisor at Health Action International, an organization working to expand access to essential medicines through research, policy analysis, and intervention projects. Jaume leads Health Action International's advocacy and campaign work on access to medicines in Europe, and is also responsible for following up and interacting with World Health Organization bodies and initiatives. And then Óscar Fernández, who's a postdoctoral researcher on global health governance at Maastricht University, and is the co-author of the Insured reports on intellectual property and public health regime complex, the World Health Organization pandemic agreement, and reforming the World Health Organization after COVID-19. So thank you all to our panelists for being here. We're now going to proceed with a brief presentation of research findings from the Insured reports, relevant reports. And just to remind you, the webinar is being recorded and will be made available soon on Civicus's YouTube channel and website, as well as on the Insured website. So in case you miss something or you'd like to share it with colleagues. So Óscar, feel free to go ahead with the presentation if that works for you.
Great. Thank you, Samuel. I will try to share my screen now, which you should be seeing in a bit. Can you confirm that you can see it?
Yeah, we can see it. Thank you.
Great. Wonderful. Thanks for the invitation. Thank you for the introduction, Samuel, and for organizing this panel. I'm really happy to participate in this. Also with my fellow panelists, thanks for being here. I look forward to to the discussion and learning from you. So I will be presenting briefly the findings of our report on the pandemic agreement mostly. So Samuel mentioned the three reports that we published through the course of 2025. But today I will be focusing mostly on the second one, on the WHO pandemic agreement and how it bolstered global health security. So, to give you a little bit of background about the pandemic agreement, I need to go back to the origins of the governance of international health security, obviously making reference to the international sanitary conferences back in the 19th century. And later on, under the WHO, the adoption of the international health regulations in 1969. Those regulations were amended later on. They were amended in 2005, and the institution, so to speak, of a public health emergency of international concern emerged as a result of those amendments. And this instrument has been utilized several times and lately for COVID and also for Mpox. A few gaps were identified in those regulations. Some clear failures also when it comes to compliance and implementation as a result of COVID. So countries decided we need to do something about that. And a dual track process emerged. So first of all, reforming the IHR, which was the obvious solution, but not the initial one. That was the one that was spearheaded by the United States as a reaction to the adoption of a pandemic agreement, which was an agreement with a broader focus than the IHR, more of a focus on prevention than the IHR, and more of a focus on equity considerations as well. And here there were two camps as well, those who believed that the WHO pandemic agreement should be a convention, and those who believed it should be a regulation. But the latter camp was mostly the United States. And that, as we will see later, sort of was removed from the equation later on, obviously. So these two tracks had the same deadline. That was May 2024. Both began negotiations in 2022. The IHR amendments were adopted successfully in 2024, but the agreement, the pandemic agreement, was not adopted. Then countries did not have time to reach consensus, and they decided to postpone the negotiations. Finally, they did manage to agree on a text in April 2025, but that was only after the US left or announced that it would be leaving the WHO, and as a consequence, also leaving the pandemic agreement negotiations. The adoption of the agreement happened, legally speaking, at the World Health Assembly in May 2025. Here you can see a picture of the moment when countries agreed on the text. This is not from the WHA, but it's from the adoption of the text, sorry, the agreement of the text back in April 2025, when one of their co-chairs really highlighted how this was a triumph for the WHO. WHO can be proud, and multilateralism lives. So this already goes to sort of illustrate to what extent countries were motivated to reach agreement to show the United States we can still make this work without you. We can still underpin the WHO without you in it. There's a major caveat here, which is that the agreement is missing a key annex on pathogen access and benefit sharing, the famous PAPS. Countries are aiming for the 2026 World Health Assembly for that to happen. It's going to be a challenge. Let's see what my fellow panelists have to say about this. It's going to be a challenge, but it's going to be something critical for the agreement, obviously, because not until is this annex agreed will the entire agreement be open for signature and later ratification. So this is really a critical part of the agreement that is still pending. Obviously, further challenges here when it comes to the text that was agreed back in April 2025. First of all, there were compromises, right? Countries needed to reached the finish line, and that means that there was modest ambition across the board. Intellectual property considerations, for example, are virtually non-existent in the agreement. There's really little on technology transfer as well. There's more about this in our first report on intellectual property considerations, if you're interested. Secondly, quick ratifications are not guaranteed. So obviously the US under the Trump administration will not be joining, but neither will Argentina, which is also trying to leave the WHO, even though legally it may not happen, and other countries that also failed to accept the amendments of the international health regulations that were made in 2024. So this includes Israel and Italy for substantive reasons, then a few others for procedural reasons as well. So this agreement will be adding also a layer of complexity in the governance of the global health security. On the one hand, the IHR are universally applicable to all WHO member states, with this caveat about some countries not having accepted the latest revisions. The pandemic treaty will not be. It requires 60 ratifications for it to enter into force. So by default, when it does enter into force, many countries will not be part of it yet. So we'll see how this sort of mismatch in terms of membership will be navigated. And finally, obviously, the WHO's financial crisis as a result of the financing shortfall left by the US gap. We talk a little bit more about this in report 3. We have one of our interviewees who said it is a contradiction to say we have just reached the most ambitious agreement in global health, but we do not have money to pay the electricity bill, right? So we have here a major problem for the WHO in terms of securing implementation. Let me move on to this slide that paints a picture of the EU's role in the agreement. The EU was the main proponent behind this agreement, and it had a stake in having the agreement become a convention rather than a regulation so that the EU could join. The EU, I may remind the audience, is party to the Framework Convention on Tobacco Control, which is the only convention prior to this one under the WHO. So the Commission obtained a mandate to negotiate on behalf of all member states, but this was very much contested also internally and externally, especially towards the end of the negotiations. So some member states were not entirely happy about the mindset that the Commission sort of brought to the table. Some of the officials that I interviewed signaled that the Commission was operating more from a trade than a public health sort of perspective, and that brought some tension to the negotiations. There was more flexibility in the final weeks, obviously, which facilitated the agreement, but the EU was seeking concessions until the last minute, for example, when it comes to making reference to voluntary technology transfer and being quite clear about including some clauses to secure that. A key takeaway is that this is a diplomatic win for the EU, especially, obviously, if the PAPS Annex is agreed. It didn't cross any red lines to get there, but an open question here is whether or not the image of the EU as a global health actor improved as a result of this process. I want to take some time to speak about democratic considerations, considering the makeup of today's panel with civil society representatives. One of the key elements that we look at as part of our report is the democratic dimension of the agreement. And here, let me start with the WHO itself, because it seems to have a bit of a mixed track record when it comes to democracy based on interviewee insights. It seems like there's considerable room for improvement in ensuring transparency and access to information, especially when considering the practices in other organizations like the World Intellectual Property Organization, for example. When it comes to the output, concretely, the pandemic agreement was an opt-in convention rather than an opt-out regulation. So democratically, this is important because it will bring parliamentary ratification into, it will be playing a role, right? So this, in theory, will underpin the democratic pedigree of the agreement. When it comes to the process, as I mentioned before, this was a dual track. The IHR reform on the one hand, pandemic agreement on the other. This was quite a difficult situation, especially for poorly staffed national delegations. It was incredibly resource intensive, and some officials indicated that this put some delegations from global south countries at a disadvantage. When it comes to relevant stakeholders, this famous name that is given to civil society organizations, but also other organizations that are invited to follow the talks. Some have official relations. Here we have one representative from an organization with official relations with the WHO. Some were invited ad hoc to follow the negotiations. There are different kinds of non-state actors, of course. On the one hand, industrial lobbyists always seem to have a little bit more of informal access to the delegations. And when it comes to civil society, there were fewer access opportunities, but there was some progress that some of our panelists perhaps want to elaborate on a little bit later. Also, obstacles that remain. So to wrap up, I'll leave it here after this slide. The pandemic agreement is a tentative win for multilateralism and a rebuke to the Trump administration to a great extent. It has some clear bright spots. On the one hand, it reaffirms the WHO's central role in coordinating international responses to health emergencies. It also codifies One Health within an international legal instrument for the first time. Nina, I believe, will say a little bit more about this later. It also incorporates equity provisions that were largely missing in the international health regulations. But the cons are that the legal language generally is quite weak, so it's quite underspecified. Also, ratification, implementation, and enforcement are very much in question. What will happen, especially given the WHO's resource crisis? There was a recent expert survey that came out as part of Ensure that you may want to check out on the WHO's robustness and what international officials believe about this. And finally, there's this risk of fragmentation in the global health security between the IHR and the pandemic agreement that I referenced before. So I think I will leave it here. Thank you very much for your attention. Look forward to the conversation later and learning from the other panelists.
Thank you so much, Oscar, for the in-depth dive into your research, and I think it gives us a lot of ideas and food for thought for the conversation that's coming up. So let's try and take a step back now and think about, for those maybe who don't have as much knowledge about the issues, let's think about what the problems are and what's at stake generally. So I was gonna start off with you, Nina. So I was wondering if you could tell us from your perspective, how did the pandemic expose weaknesses in our approach to health governance, and particularly regarding the complexity of the global health regime?
Thank you for the question. And it's an interesting question to get as an animal welfare organization, because we are not a public health organization. I have studied public health, but the fact that we are part of the discussion right now is one of the indicators of what was not the case before. So we all know we were not prepared for the pandemic when it took place. We saw inequities. We saw health systems that were not resilient, in most cases also under-resourced, and governments viewing health as an expense, not a public good to invest in, not seeing health for all as an outcome. So we had a situation where when the pandemic happened, we were not ready to deal with that emergency. And that indicates the first weakness of health governance and the way we develop health strategies. They are focused on symptom control after the emergency. If you look also at the way the WHO was structured, the department dealing with epidemics and pandemics is focused on preparedness and response, not on prevention. And when the pandemic happened, scientists had known the drivers of disease outbreaks. They had been warning about them, but there was not enough collaboration across sectors. This low coordination, we saw it also in the negotiations. What we also saw in the negotiations, so if we think about the beginnings of the negotiations, governments were not thinking about prevention. When the decision in May 2021, I think it was during the World Health Assembly, to consider whether to negotiate a pandemic agreement, the title of the agreement was on preparedness and response. It was only in December that year, when the decision was made to initiate the intergovernmental negotiating body, that prevention was added. And that was due to advocacy by organizations with whom we've worked, so for Paws and many other conservation, animal welfare, animal health organizations who noticed the gap. It was the result of governments who had been proponents of One Health, realizing that we can no longer just focus on symptom control. It was also the work of academia and experts that led to this conclusion and adding prevention to the scope of the treaty. However, we still saw pushback. Our first debates with member states, the responses that we got were, it's not the job of the WHO to deal with animals or the drivers of disease outbreaks. But if those sectors do not do their part, then we will always have a situation where the health system is going to inherit a crisis that was created by other sectors. And that was, in our view, the main weakness that was exposed. Of course, the inequities, the way that vaccine procurement was handled was absolutely inequitable. Health systems, healthcare workers had several challenges, but the biggest paradigm shift that we saw with the pandemic agreement was having this additional scope on prevention and having One Health as a standalone article in the treaty. So this was the biggest change that we saw, and it means that health strategies are going to be developed completely differently in the future on national and international level. So it's going to be a new way of working, and hopefully a way to also save costs, because as you mentioned, there is a financial crisis that's tied to health. Health has already been anyway under-resourced, and now it will suffer with additional financial challenges. So investing in prevention, which costs a fraction of preparedness and response, might also be a helpful measure.
Thank you for that. And I find it particularly interesting the angle that you made that you described on vaccine inequity. And so I was thinking that Jaume, maybe you could go in depth about that issue. From your advocacy work at Health Action International, what do you during the pandemic, could you describe the impact of vaccine inequity and the IP barriers on access to treatments?
Thank you for the invitation and also for this question that I think it's extremely relevant. I think it has already been mentioned by Óscar and Nina that there's like a feature that it's very important to bear in mind is that when COVID hits, it doesn't hit in the body. There are already existing patterns and trends. And when it comes to access to pharmaceuticals, there are like two characteristics which I think are important. First, like medicines, like the most innovative medicines would always, well, they still do, would always arrive to the most lucrative markets. That's first. And second, IP-based monopolies, patent-based monopolies would make high prices last longer, would be like an obstacle to access. So we have these two factors that already existed before the pandemic hits that really made the response to COVID more, we can say, inefficient. But the result was like this inequity that you were mentioning. And for me, this inequity and a little bit what like Óscar was also mentioning, like some of the insufficiencies of the international health regulations from 2005, like facing this pandemic, I think there are three phases which really tells us a little bit about what was going wrong at that moment. I think that the first phase is like around like March, April 2020, when there's the outbreak and there are like the first like high number of cases of COVID-19 in Italy. We see then there is like a scramble by a number of EU countries and others, like for personal protective equipment and ventilators. So the issue here is like at first we see that the problem was not medicines, it was not vaccines, it was other health goods. And this is really like what Nina was mentioning about health systems, how health systems were prepared to really respond to an emergency of that scale. Then there is a second phase that it's like when there is like, I don't know if you remember, there were like some reports that said that remdesivir could be effective against the symptoms of COVID-19. And then we see something very interesting. There's like a run by several countries to get like as many doses of remdesivir as possible. But also we see, and I think that Alexandra has been working on that direction, like several countries that either issue compulsory license or like amend their legislation to make it easier to enact compulsory license. This is the case of like Hungary, Indonesia, Canada, and even Germany or Israel. So this is very clear, like that governments, it takes a public health emergency, a pandemic outbreak, for some governments to acknowledge that IP can be a problem to access like health technologies. And I'm sorry that if I use like terms like compulsory license or patents and it's no clarity, please put a line in the chat and I stop because we have this tendency, like we are really weird people and we use this lingo to make us look important. So for me, like the third like phase, and I think that it's really the one like responding to what Samuel is mentioning, comes when we have the vaccines available. And there are like two things that we have to say about these vaccines. First, that there was like a massive like influx of public money in the development of these vaccines. That's something that is there. Even though like pharmaceutical companies took a risk and there were investments, but without the support for research, we wouldn't have those vaccines. So the problem that we have here is like that EU again and the US, Australia, UK really like hoarded like doses, but like buying all the doses, but even in advance before production. You see, even when they were like just promising, and that really makes the situation that not only that were no more doses in the market, but also international mechanisms that had been created to ensure this equitable access to vaccines, like namely like the COVAX mechanisms, like through WHO, were unable to secure these doses. So developing countries were made to wait. And it's not like you are waiting for a table at a restaurant. No, I mean, you're being told that your citizens are falling sick and cannot work, and you cannot really take care of them because you don't have access to these markets. And then there is something, and also when Óscar was presenting his slide, really, I think it's very graphic in the sense that during like 2 or 3 years, we had different processes, different parallel processes going on. And I think that it's really for us like high, like there was like different like responses and options, like high and others. We were really advocating for a TRIPS waiver. TRIPS waiver was a proposal from South Africa and India that was like submitted in 2021, and like grosso modo, it really said that we should not be applying like the TRIPS agreement on vaccines and other health goods. In a sense, it would be some sort of really like compulsory license to really enhance access. There was like a very strong opposition from the US and the EU. And here it's like the parallel process that we were saying. We have like the EU, like the Council of the European Union that proposes, like in 2020, like the idea of a pandemic treaty. So when India, South Africa, and like at the end, like in 2022, it was already like a high number of countries that were supporting this proposal, and really a lot of civil society organizations were like putting pressure on the European Union to consider this proposal at the World Trade Organization. We were told, no, don't worry. We're going to draft a pandemic accord. And in this pandemic accord, we will deal with all this. We will deal with IP, we will deal with transfer of technology. Of course, I'm being provocative. It was not that they only referred like IP and transfer technology as topics that are not to be found or to be found like explicitly in the pandemic accord, but it was said, no, like the space to negotiate is going to be in this pandemic accord, that we are going to open negotiations, and you have all the process of the pandemic accord negotiations. And it's really like the issue. It's also something that needs to be bear in mind, in the sense that like the pandemic accord negotiations starts when the pandemic was still going on, was still a reality in many countries. And then like the considerations of access and equity were really high in the agenda. But it took like 2-3 years, and this kind of memory sort of was not that important. And the issue, I really believe there are like two conclusions, in the sense, and don't let my boss hear that is being recorded, but there is like a failure, like in the, at least for Western civil society organizations, we were not able to convince our public opinions, our like domestic audiences, that it was all right to wait for the vaccine to make sure that healthcare workers in developing countries had access to these health technologies. It was clear that people were sick of the lockdowns, people wanted the vaccines, and they wanted to go back to their lives. And then I think that the issue of like inequity was like in the agenda, and it's really very much in the agenda now, but it's unclear that there is like the political will to tackle it, in the sense that we can see it in other like spheres and discussions where the issue of like, it's like the imbalances in wealth, it's like the disparities in terms of access to technology. It's very much in the conversation, but there are no really viable solutions that are being put forward. And also for me, there are like two things that I think that we're going to be talking about WHO later on, but there are two things that I think we need to be very honest about, in the sense that while we all defend WHO as the reference, like public health agency at the global level, like in the management and response to the pandemic, it was not really stellar, like the record. We see like what happened with COVAX, that was really late to deliver doses to developing countries. It's true that it was hindered from the beginning by the fact that like wealthier countries did not use this facility to get their doses, but still it was really a botched operation, with like they had at the end money that had not been spent, and we are talking about like almost billions. And secondly, there was this proposal of the CETA, the COVID-19 Technology Access Pool, that was like an attempt by the World Health Organization to really ensure this equitable access by pooling intellectual property and know-how of technologies that could respond to the pandemic. Again, there was no political will, and the response to this call to pool intellectual property was rebuffed by the industry explicitly, and it was more or less endorsed by 2 or 3 governments that share technology developed by public institutions. So for me, and this is going to be like the conclusion, I think that it was, for many people, it was the first time that they saw since the AIDS epidemic in the 80s, 90s in some Southern African countries, like the impact of IP on access to health technologies. That was good that people realized that. But my second point is that like the limits of this realization, and also we've seen with the pandemic occur that we are constantly being asked to choose between what is necessary and what's possible. And that's really a tragic choice if you think about it. Thank you.
Thanks very much, Jaume. Yeah. I think that's a lot to think about. And well, now we've mentioned the pandemic agreement numerous times, so I think let's go into the in depth on this. And I'd like to give you the floor, Alexandra, to give us your thoughts on the pandemic agreement, what the key provisions are of the pandemic agreement, which was adopted in May 2025, and what are its main strengths and limitations.
Thank you, Samuel. Also, thank you to Ensured for the invitation. It's really also nice to see some friendly and familiar faces on the panel, and hello to everybody who's joined online. So I'll try and keep this as brief as possible. Generally speaking, there are 5 categories of obligations in the pandemic agreement, and they sort of run through the life course of a pandemic. And then some governance elements there. So the first is really about prevention at source. And I think Nina is probably going to talk about this at length, so I'll be brief. The preventing a pandemic before it spills over and becomes an emergency. And that's really negotiated through national plans at the national level. So countries are asked to build some minimum requirements to prevent a pandemic, identifying, for example, high-risk practices that could lead to spillover. Elements like surveillance and infection prevention and control. And all of this is done through a One Health approach. The second category is really underpinning the core of the IHR in a way, and this is on preparedness capacity. So it has some obligations about strengthening health systems underpinned by a framework of universal health coverage. And there's also some commitments there by states to strengthen their health and care workforces, because we know that they were put under quite a lot of pressure in the pandemic. The third big category is really about providing equitable access to countermeasures and creating this ecosystem from development to deployment that really enhances equity sort of at every juncture. And so there's a series of obligations here. The first is to strengthen regulatory capacities. There's some obligations in there about the research and development capacities to both strengthen them, but also some quite innovative provisions about including provisions on equity in publicly funded R&D contracts. We move then to ensuring that there is a better geographically distributed health product manufacturing, because I think in the pandemic you saw this concentration of manufacturing capacities in high-income countries. So the idea of this is to sort of spread them a little bit evenly around the globe. We then see some commitments to promote technology transfer. There's a lot covered in this report about the weaknesses of the language in there, but there is some voluntary technology transfer or willingness to promote technology transfer in there. The next in this sort of bucket is about setting up a pathogen access and benefit sharing system, and the details and contours of that is actually being negotiated at the moment. But in principle, the pandemic agreement sets up this PAB system, which is essentially a multilateral platform for the sharing of pathogens and the equitable distribution of benefits like vaccines, but also other benefits like scientific cooperation that tend to flow from their use. Then there's a new WHO coordinated global supply chain network that's set up under the pandemic agreement. And then similarly to the R&D provisions, there's commitments on procurement and distribution, including similar provisions on equity in those procurement contracts. So including throughout sort of the development process, some measures for enhancing equity there, just to really change that environment. So there's less reliance on charity the next time that there's an emergency. The next bucket is, I think, what I would probably describe as sort of societal obligations. So there's a commitment by states to approach pandemics with this whole of society approach. So it's not just health systems and health ministries that are responsible for tackling pandemics. We recognize that they have enormous socioeconomic impacts and involve, as Nina explained, multiple ministries across government. So it's really taking this whole of society approach to pandemics through their life course. And then a secondary commitment to improve pandemic literacy among populations. And I think those commitments are quite important because we saw how much misinformation and disinformation impacted pandemic response in COVID-19. So it's ensuring that the population at least understands and has some literacy to respond to a pandemic. And the final big bucket, as lots of treaties do, is I think some obligations around enhancing cooperation, financing implementation, and governance. So to begin, countries have commitments that they're going to cooperate with one another. I think the language around this is pretty hazy, but generally there's a commitment that they are going to provide support to one another for implementation, but also in response to a pandemic, but particularly by providing additional support to developing countries who may have like smaller fiscal space to implement policies, and also fewer resources when it comes to responding to a crisis. In terms of sustainable financing, there are really sort of two pieces to this puzzle. The first is about financing things at the national level. So states have commitments to just really strengthen their domestic financing for implementation of the agreement from pandemic prevention through to response. But there's also an international component there. So the pandemic agreement is establishing a coordinating financing mechanism to support implementation. And there's some language in there that says that this is going to be the same mechanism as established under the international health regulations. So this is one body that's going to support both preparedness and response capacities under the IHR and the pandemic agreement, because there's going to be considerable conceptual overlap between those as well. And that body is going to have sort of some powers to send money where it's needed and do the assessments to work out where money needs to go. And then finally, there's the governance components. So like the FCTC, like the UNFCCC, like the CBD, this treaty would set up a conference of the parties that would meet regularly and can set up its own subsidiary bodies like technical advisory boards. And it also has the powers to expand the normative framework of the pandemic agreement, say, for example, through adopting guidelines and recommendations, which would be non-binding components, and also to adopt annexes and protocols, which would be binding components, and just to continually expand. And this is a conversation that came up in the negotiations a lot, is the idea that the treaty is not frozen in time, and that with emerging science, emerging normative developments, that the ecosystem can expand, like we have seen so frequently through the COPs under the climate agreement. And it also has the power to set up a mechanism to support the treaty's implementation overall. So kind of like an implementation body. In terms of the strengths and limitations overall, there's strengths and limitations attached to every single provision. So I won't get into that in detail. But I think it's important to note how remarkable it was that this treaty was adopted at all. I think in the context of just how much distrust there was between parties to these negotiations, given how politically fraught the COVID pandemic was, and such a hard time for multilateralism overall, I think it's quite significant that a compromise was reached. In terms of specific strengths, I think it achieves what it set out to do. It goes beyond the IHR in terms of scope, so it covers the pandemic prevention that the IHR doesn't touch, which is significant there. But right through to health system recovery after a pandemic has occurred, and I think that's also quite an important element there. And as others have discussed, I think it entrenches equity a little bit more at every juncture. And I think particular provisions I want to call out are going to be game changers. The One Health response, it's the first time that a treaty has recognized the One Health approach in a binding agreement. That's significant. But I also think particular provisions like agreements to put conditions on publicly funded R&D and procurement contracts are actually quite monumental. The language on health, the health and care workforce is very strong. And I think the PABs could be quite a game changer depending on how the negotiations in the current IGWIG pan out. As far as weaknesses go, I think Oscar's covered a lot of these, and I suspect there's going to be more in the reports for those of you who are interested. There's a lot of caveats in the text, and there's a lot of voluntary legal language, like we agree to promote, we agree to consider, we agree to encourage. You'll see these sort of dotted through the text. But on the flip side, I feel like the treaty might have been a little hard to adopt in certain places without this language. So it's all about compromise. I think in essence, what the text does do, despite that language, is it provides a firm foundation for governments to act on pandemic prevention, preparedness, and response going forwards. And I think it's up to us as civil society organizations to first and foremost press governments to finish their work on PABs. Secondly, to encourage countries to ratify, to sign on to this treaty when it opens for signature. And third, once they've actually done that, is hold governments to account for the commitments in there. So I'll pass it back.
Thanks very much, Alexandra. That's really interesting, and it feels like this is a really wide-ranging treaty, but there's some unfinished business, as you mentioned. So let's talk a little bit about the PABs, which is the Pathogen Access and Benefit Sharing Annex. So, Óscar, I was wondering if you could explain what's at stake in these current negotiations on the PABs Annex and why they're so critical.
Sure, thanks. So Alexandra already told us a little bit about what's at stake when it comes to PABs, but let me go into a little bit more detail. Well, first of all, what's at stake is the whole agreement, as I said before, right? Because countries decided that PABs would be an annex, and therefore it's integral to the agreement. It's not a protocol, which would be adopted as a separate sort of instrument, and it wouldn't compromise sort of the agreement per se, right? So it's an integral part of the agreement. And Global South countries in particular push very much to ensure that the main body of the agreement and PABs would be one and the same thing, and therefore this would reduce the risk of fragmentation and free riding. But PABs is also important for a substantive reason. I mean, it's been described as the cornerstone of the agreement, which is interesting enough if you think about it, because it's that is to say that the agreement as it stands is lacking its most critical element. But countries decided to postpone negotiations on this to try to make the 2024 deadline, which they missed anyway. But then later, thankfully, they did make the deadline a year later. Under the PABs framework, essentially, countries are expected to promptly share pathogen samples and genetic sequence data, and in return, pharmaceutical manufacturers using this data must share the benefits. So that's very much the bargain that countries have struck. And the key commitment here, as it stands, and that's already in the text of the agreement, is that companies will need to provide 20% of the real-time pandemic production to the WHO for distribution based on public health need. And at least half of this, that is 10%, would be donated outright, and the rest would be offered at affordable prices. So that's something that is already part of the agreement. The questions that remain are very many and very technical and very complex, also political. So when I say technical, that's not to say that it doesn't have political dimension, but it does get very detailed, right? For example, the definition of pathogens with pandemic potential. Who are the so-called participating manufacturers? That's a term that appears in the current text, but is yet to be defined. How can participating manufacturers entities be driven into compliance? The PABs framework is to a large extent based on the pandemic influenza preparedness framework that already exists in the WHO, which itself struggled to secure payments from companies. So let's see if the PABs is more successful on that front. Intellectual property is also another front. The pandemic agreement, as I said, is largely silent on that. Also, the article on PABs, Article 12, The current draft on the annex does address intellectual property, but it remains highly contentious. And finally, also the distribution of these vaccines, therapeutics, and diagnostics, as I said, shall be based on public health risk and need, but how exactly is this determined? Will the criteria be made public? These are all open questions. The PABS instrument might not end up addressing all these questions. So there will be political compromises for sure to reach agreement, if possible, by May 2025. So the final text will be important, but also we will need to see, if approved, what the text does not say, not only what it says. So yeah, let's wait and see.
Thanks very much, Oscar. Yeah, as you say, the process is becoming increasingly political, and so I'm interested in understanding these political dimensions as well. And so I wanted to go back to you, actually, Alexandra, and ask you what, with these PABS Annex negotiations ongoing, what are the points of contention, and what are the, particularly around the North-South divides, but what is the current state of play regarding the stakeholders involved?
Guys, thank you, Samuel. So I can really give an update based on what happened in the last meeting that I was at in so early December. I think one of the issues that's emerged is about the idea of legally binding contracts as underpinning the entire PABS system, generally speaking. I think countries are aligned that they should be that legally binding contracts should form a big part of the PABS Annex. I don't consider that progress, given that that's text already in Article 12, but that's another issue. So I think there are sort of two questions related to contracts in which you've seen this sort of north-south divide. The first is really about who decides the contents of these standardized contracts. So the question is between, is this a job for the IGWIG to sort out, or is this something that the COP later can decide once the pandemic agreement is in force? And so generally speaking, the Africa group and the group for equity believe that the annex should have all of the operational details finalized, including entire standardized contracts, and not be deferred to the COP. And so in furthering that approach, they've actually developed some fairly loose contracts, largely inspired by the PIP framework. And these are actually available publicly online if anyone was interested in reviewing these draft contracts. A couple of them they've developed, so on data access, and then two governing the transfer of material and sequence information with different users, recognizing that there are probably going to be different benefit sharing obligations that attach to, say, for example, a researcher in a lab or participating manufacturers. And they're arguing that this is essential just for two reasons. The first is that it would give governments clarity about whether they actually want to sign on to the pandemic agreement at all. I think because the core benefit sharing obligations is one of the things that they've been seeking since the beginning of the pandemic agreement negotiations, because they weren't outlined to an enormous extent in the pandemic agreement. This process felt like it got shifted to the PABS negotiations, and they're concerned at this point that it's now going to be shunted again to the COP, and they have less and less leverage as this process goes on. And also to the problem you just mentioned about free riders. So avoiding this free riders problem where you would have users of pathogen material and sequence information who can make use and make profit from these genetic resources without corollary obligations to share benefits from them. Where you have high-income countries, the EU included, on the other hand, believe that there's just simply not enough time in the negotiating calendar to sort out entire standardized contracts, particularly the ones of the length that these other country parties have proposed. And there's not enough expertise, so they'd probably like to see some commercial lawyers in the room in the COP and have some technical conversations about what's a good contract, what makes a contract enforceable, and that they should instead prioritize some of the other core requirements of the PABS Annex and just agree to some minimum requirements in the time that they have left for these contracts. I guess the other the issue relating to contracts is this kind of tension between benefit sharing and open access platforms, and whether access to PABS materials and sequence information should be granted only upon entrance and conclusion of a PABS contract. And so again, we're seeing this divide. with the Africa region and the Group for Equity saying we need to ensure that benefit sharing, and the way to do that is that we agree a contract before access is granted. Because pointing to how databases work, the numerous databases that exist at the moment work that are purely open access without even registration commitments, there's a worry that those are not flowing to benefits, and so they want to change that with the PABS system. And on the other hand, you have the EU and other high-income countries who would say that even registration processes, for example, would undermine open access, which again is in Article 12. So this commitment to ensure open access and scientific progress is written in there. And also the fact that this system needs to be timely and rapid, facilitate rapid sharing of sequence information and materials as a public health good, relies on fast access. And if we include all of these requirements early on, it would actually dissuade and undermine that sort of rapid access. So there's quite a lot of distance here, and I think this is becoming the sort of the meat of the negotiations at the moment. The challenge is really how we're going to find a way forward. I think some proposals have emerged about whether you can have just a receipt of a notice upon registration, that at some later point you may have benefit sharing commitments. I don't know how palatable that is to some of the negotiating parties, but even the question of commitments upon registration is not comfortable to certain high-income countries as well. So there's a lot of distance here, but we are quite early, I guess, on in these negotiations. I guess other issues that are political, I think Óscar mentioned some of these. So with the use of terms, how to approach a pathogen with pandemic potential. Is it a list? Is it criterion based? I think there's convergence around some sort of hybrid approach, similar to how it's dealt with in Annex 2 of the IHR. The definition of a participating manufacturer. What happens when you have a developer, for example, a developer is included in that definition? If so, when are they included in the definition, and how do contractual obligations flow through that change? And if they do change, how would the PAB system actually monitor a transition from a non-commercial use to a commercial use? And when do the benefit sharing obligations attach to that transition? So lots of questions. There are governance questions that are still yet to be decided, but I think they're probably less hairy than the one about contracts, binding legal contracts.
Okay, thanks very much. So it seems there's still a lot of points of contention, and it's still early days, I suppose, in the negotiations. But I wanted to come back to an issue which we've been bringing up, and which is the One Health approach. And so I was wondering, Nina, if you could, from your perspective, especially with Paws International, give us a bit of, I suppose, description of what the One Health approach of pandemic preparedness is, and if there are any opportunities to strengthen these connections with the PABS framework as well.
Indeed, it's a good question. We need to keep in mind that PABS Annex is part of the treaty. It's one of the pieces of the puzzle. So all the other articles and what we enable through them will have to interlink and be complementary. The One Health approach has been updated after the pandemic by the One Health high-level expert panel. It was a panel that was assigned to advise the quadripartite organizations, so the WHO, WOA, UNEP, and the FAO. And in their updated definition, they came up with a more comprehensive approach, which is also linked to the evolution of One Health. So the purpose of the One Health approach is to foster well-being and to tackle threats to health and ecosystems. So it moved away from being an anthropocentric approach where we only start thinking about what to do after animals and the environment affect humans. So sick animals or polluted environment affect humans. Now with the OLAP definition, we're also looking at what are we doing as humans to drive diseases and to threaten ecosystems that then makes us sick. So it became a more ecocentric approach. And it is rooted in two key areas. One of them is prevention by tackling the root causes. So early interventions, the earliest possible interventions. And the other part is collaboration. across sectors, because health does not exist in isolation, and we need other sectors to start taking action before an emergency. So addressing the drivers through collaboration. What it would enable then would be more effective strategies, because if we think about the treaty, there is language on whole of government, whole of society approach. And this is also what One Health is about. It's about involving communities, people who come into daily contact with animals and are at the front lines of an outbreak would then be part of the strategies to prevent disease emergence and spread. The different sectors, so the academic sectors focused on veterinary medicine, doctors, medical doctors, environmental scientists would then also have curricula where they work together. And this is also, there's language in the treaty about this. The efforts to undergo surveillance of diseases would then also be coordinated. So we'd have coordinated multi-sectoral surveillance. The data that would be gathered would be more coordinated as well. So we'd have data interoperability. If a disease is detected in animals and is reported to the veterinary service, and we would have joint databases, then the Ministry of Health would have that information much quicker and would be better able to take action or to prepare, to anticipate. They would be able to better support each other. Through the One Health approach, we anticipate also that governments might have then joint labs where they are testing for certain pathogens through similar processes for humans and animals. And these more practical areas are where there could be an intersection with PAPS Annex. The quick sharing of pathogen data could be strengthened through the infrastructure that would be built or enabled through the One Health approach. What we're also looking at from an animal welfare perspective is whether the PAPS Annex and the definition of pathogens with pandemic potential will begin with pathogens that spill over, pathogens in animals, because then it would mean that the PAPS Annex is better connected with Articles 4 and 5 on One Health and prevention, and that the efforts that are undertaken by the other sectors also help the health sector and also inform the purpose of the PAPS Annex, which is making sure that countermeasures are developed as quickly, that health equity is ensured. So it would be ensured through better prevention, but the infrastructure that would be enabled through efforts to implement the One Health approach to prevention will also support.
Thanks very much. Yeah, I see that this is a really important part of the pandemic agreement, and I was wondering to what extent, well, civil society in particular can be involved in this process. So I wanted to ask you, Alexandra, to what extent are you satisfied with civil society in particular and non-state actors' participation at the negotiating table? Have they been granted meaningful access to these discussions?
In short, no, not particularly. I think we've had the sort of opportunity to expand access a couple of times in the IMB. There was a small number of actors opposed. I think the larger majority of member states actually did want civil society more actively engaged. So for anyone who's not currently aware, civil society is not allowed into closed-door negotiations. So relevant stakeholders, we can be there for a short briefing. It used to be at the beginning of the day, and now they've moved it to the end of the day. And the IGWIG has been conscious to introduce sort of shorter, slightly longer briefings for relevant stakeholders. We had one, for example, in the middle of the week, in early December. But I think in this process, it is increasingly more political. So I get the sense that there are a larger number of member states who are more opposed to fuller participation. So I think that it's not ideal for a couple of reasons. mainly because civil society and relevant stakeholders are going to be the ones who are really advocating the treaty to governments, but also the public. And there's already so much misinformation and disinformation around just the content of the treaty. There was so much discussion about how the treaty was going to rip away sovereignty from governments, and WHO was going to use it to control populations during health emergencies, which is just simply not the case. And so I think having us in the room would be, would really facilitate those conversations a little bit more. But it also means that our time spent as relevant stakeholders is just working out what's been said and who said what, and how, rather than how we can best help to find some consensus language and shop it around. So it has been challenging. It's not been impossible. And I want to encourage everybody here to sort of stay engaged in the process as much as we can. I know that the co-chairs and significant numbers of member states are really find it important that we're participating in the process. I know that it hasn't really reflected how negotiations have happened in other contexts. And that's just something that we'll probably have to reflect on at the end of this process and just make do with the arrangements that we have at the moment.
Thanks. Well, I also wanted to open this up to Nina and Jaume, because perhaps you have some points to make as well on this issue, which I think is really relevant.
Sure. I'll be quick so that you can hear us, Jaume. The modalities of engagement for the process remain the same from the beginning of the process. The reason why we did not have access was because member states did not want to offer us that access. And as Alexandra mentioned, other processes they go about involving NGOs and relevant stakeholders in a different way. There are discussions which NGOs are able to monitor and listen in on. NGOs are also able to deliver statements before certain decisions are made. However, on the plus side, it's also, as Alexandra mentioned, if we are in the room, we would then spend time figuring out who said what. And it would have been a situation where member states would not have been as open with each other as they would when we are not in the room. Otherwise, so the way that we managed, because as Alex mentioned, we did manage, we then ended up talking to all sides, so different member states, and getting their assessment and their view. And in the end, it turned out that we were getting a better summary of what actually happened, and we're able to ask follow-up questions on the reasoning behind different concerns, and we're able to help clarify those concerns, because when we were out of the room, we were getting the very brief summary. We were not getting exactly what was said. Would not get a full explicit explanation of concerns, but we found a way to go about it. So in other processes, we had plenary sessions which were open to NGOs, but also closed sessions where member states would then be able to speak freely, and that kind of mix would be ideal. But with the WHO not being a home for so many international negotiations, it is also possible that it would take a little bit longer for us to see more open processes there.
Yeah, I think regarding like society participation in this specific process, I think that HIGH, as many other organizations, we are highly critical of how WHO member states are managing the whole participation by non-state actors. But it has to be said that they made an effort, in the sense that at first it was only those organizations that had official status with WHO that could attend or follow negotiations, and then they opened it up to other organizations that governments would submit their names. So there were like more organizations following it. But as Alexandra and Nina are saying, I mean, the opportunities for interaction are super limited, very structured, and really not convenient when you want to really engage and influence an ongoing negotiation. I think it was Óscar that mentioned like the difference, like in terms of democracy, with other Geneva-based organizations. And it's like what Nina is mentioning, like you go to WIPO and you see NGOs like following deliberations and delivering statements and having really like an ability to interact with delegations that even though in WHO is possible, because right now with the reforms, the cafeteria is next to the negotiating room, which is quite convenient. But the issue here, it's also, I think that the key is really, do governments want NGOs to be hearing what they are saying when they are negotiating? Of course not. I mean, that's like the secret of diplomacy. Like, but at the same time, I mean, I think that there is a degree of accountability, because we are also not mentioning something that I think is the elephant in the room. It's that the pandemic accord is really very unpopular in many countries, especially like for instance, the Netherlands could not support like the resolution that really approved the pandemic accord, not to talk about like the US. So when it's really like negotiations are held behind closed doors and there is no accountability, it doesn't help. And sometimes it feels like society are the ones really pushing the process, really like rooting for the pandemic accord, really like providing like the technical expertise and really raising the issue. For me, it's really interesting that like it's really like the European Union. No? The European Commission says we support like the participation of civil society. And then they go close doors and they say, yeah, but someone else opposed it, so we couldn't do anything. And it's like, for instance, like Russia and Saudi Arabia oppose continuously like the participation of NGOs. And there's like a larger problem at WHO with participation of civil society. We've seen it in the World Health Assembly, we've seen it with the executive board, like, because we have really long agendas and it's really hard to fit all the items that needs to be discussed, like the participation of NGOs. It's really, now we are asked to deliver statements under 1 minute. And the problem is like, for an NGO to spend like 3-4 days in Geneva, it's a lot of money. To go there to deliver a 1 minute statement makes you wonder, you see. And I think that the issue with this process with now with the PAPS week, it's a little bit like this as well, in the sense that yes, you can follow like the briefings, like that there are webcasts in the mornings, but to be there like 4 or 5 days, it's really expensive. And I think that there is like something here that needs to change in the sense like to, I don't know, for this process or the next. At the same time, I wanted to go back to what we said by like, I think it was all the panelists, but I think it's super interesting how this pandemic agreement discussions covers all the issues that we have been working on access to medicines. I mean, in the sense like IP, technology transfer, manufacturing capabilities, One Health. I think it's really like to get an idea of how difficult it is, like that we are addressing all the problems at the same time. And now it's really, of course, like the PAPs, it's like the most difficult and untractable of all. So it's really a challenge that the international community is facing here. But also, I'm a bit afraid that anything that we agree is going to be a victory for multilateralism. And well, I think that we need something, you see, not just like a couple of lines and that's it. Thank you.
Thank you very much. Yeah, I just wanted to think about the civil society access more deeply now, and I think I wanted to come back to you, Nina, to talk about the how we could maybe bridge the north-south divides that are evident in the PABS negotiations, and how could civil society work across these divisions, perhaps to find more equitable outcomes.
Indeed, this will be, it will remain a challenge, but it feels like after the pandemic agreement negotiations, some of the trust deficit that occurred during the pandemic and the way that was handled was slightly remedied. At the beginning of the negotiations, what we saw were different regions coordinating on their own. So there wasn't enough dialogue. And then we started seeing interregional coordination. So for example, on One Health, there was a group of friends of One Health that was from different parts of the world. It was a truly diverse group of countries that engaged in coordinating positions and views, or just convening to have discussions and see what others thought. With time, we saw an increase in interregional communication, and that's one of the key essentials. It's an essential for bridging the North-South divide, because when governments are in the negotiations, and especially when their capitals are listening in through Zoom, they repeat their positions. They do not explain where they're coming from. And the other side makes assumptions. And when there weren't any informals, because some groups of countries insisted that the discussions happened in plenary, those kinds of clarifying conversations were not taking place. So what we then saw was organizations like the International Peace Institute convening retreats, bringing member states from different regions together ahead of negotiations, so that they have a space where they could speak more freely, explain their views to each other, and try to find potential landing zones. That is one of the ways to clarify and achieve progress. But with the PAPS negotiation, and as Alexandra was mentioning, it is technical. So there will be elements where experts will need to come in. There will be elements where additional analyses will need to take place. So it will not be enough for member states to share where they're coming from. So the developing countries want the contracts because they believe that this is the way to guarantee that. So this is the most essential part of the PAPS Annex. It is the way to guarantee equity. Without these contracts, they don't have that, and they do not want to wait until the COP. The other side is saying it will take too long. We will not be able to finalize it in time. So that challenge is both technical, but also linked to trust. How do developing countries then have the sense of security that during COP, the negotiations on the contracts will not take decades? And where we would then come in as civil society organizations, academia, would be, on the one hand, to do the analysis that is necessary, summarizing different options, trying to propose solutions, convening spaces for interregional dialogue, but also us coordinating amongst ourselves and speaking as much as possible in one voice. This is a type of effort that we also saw during the pandemic agreement negotiations. There were settings where NGOs came together and spoke in one voice about how to ensure equity, or the absolute essentials that have to be part of the agreement, or at the critical moments towards the end of the negotiations, sending a signal that we wanted member states to get the treaty done and to see the treaty as a beginning, not as a final destination. So there will be a lot for us to do, and it would help us if member states are open and sharing what their challenges are, so that we know how to be most useful. And that's the part that still needs to get improved as well. So we can do our part, but we need them to also be forthcoming with us on where they are stuck, and to be forthcoming with each other on why they're blocking or why they're acting in a certain way so that assumptions do not drive a downward spiral.
Thank you, Nina. Well, I was wondering, Jaume, if you could add on to that as well. And in your view, do you have any ideas what the most strategic entry points and opportunities for civil society might be to influence this process? And do you have any idea what advocacy strategies are most effective?
I think that Nina already points out like what can really work at this stage of the negotiations. I think that the retreat that was organized by the Peace Institute, and I think also like the Swiss mission was organizing something similar. I think it's really important to get this dialogue going, especially as Alexandra was saying. I mean, by April, the degree of mistrust and bad blood in the room was like notable, and I think that there's like a level of personal rapport that you need for these negotiations to really flow. And I think there's this reliance on experts that it's also problematic in the sense what experts you see, and I think there is a valid point saying it cannot be like experts from like Western organizations or Western-based institutions. So I think that we can provide this information as well, in the sense that we know that there are voices in the global South that have not only the knowledge but also the perspective to share with the negotiators. But I think that again, it's what Nina was saying. I think that the issue what we can do best is making the case for the agreement in our domestic public opinion, so regional and the European level. I know I just said that we failed at COVID, but now it's going to be different in the sense that I think you see, because that's a little bit, we have this tendency, like I think that's my personal opinion with civil society, that we really talk a lot with each other. And we forget about the importance of really transmitting what we are doing, sharing what we are doing with the wider public. And in this case, I think it's really, I don't know, because the issue, for instance, we have like now there's this flu that no one knows where it comes from. So maybe we can explain, you see, what happens with virus, like they mutate, and that's why it's important that we have measures of control and prevention. And you see, they are negotiating this treaty now that maybe you should be paying more attention. Something like this. But also, it's really difficult to keep like this level of dedication. I mean, Nina and Alexandra can really witness to that. This level of dedication to a single topic for such a long time. Really, it's hard. It's hard. So, but I'm optimistic. I am optimistic.
Thanks very much. Well, Alexandra, I just wanted to direct a final question to you. What's the role that the EU is playing specifically in the PABS negotiations and in implementing the broader pandemic agreement? Do you think it can, well, how can it leverage its influence to promote equity?
I think as before, the EU is negotiating as a bloc. We're not seeing, country member states diverging from the EU position. I know that the EU has played a bridge building role on some issues, not all, namely technology transfer and pandemic prevention in the past. But I think it really needs to step up and play that bridge building role again. Convergence is so important if we want to see a pandemic agreement open for signature. And it's in everybody's interest if we get PABS done. In terms of ensuring equity, I think it's important that equity is built in with benefit sharing and access on equal footing, but not just rhetorically. I think that needs to show in the PABS Annex in practice, not just for achieving equity, but also because it will be a factor in considering whether the PABS Annex at all could be considered a specialized international instrument under the Nagoya Protocol. And so I think the EU will need to step up to really gravitate towards some of those cross-regional negotiating groups, like Nina discussed before, and potentially make some concessions. Like, we're not going to get out of these negotiations if everybody gets their red lines. It's just not possible. So I think finding some space in between is going to be really important. And the last thing I think I'll say is that the EU should, I think, make sure that the text of Article 12 is not reopened or diluted in these negotiations. The countries worked so hard to agree in principle to what the PABS instrument and annex will look like in Article 12. I think just reinforcing that as much as possible. If anything, being optimistic about what the pandemic agreement can add once PABS is finalized. We can even look towards September, for example, with a high-level meeting as an opportunity to drum up support for ratification. So I think that's a role that it could play again.
Thanks very much. Well, I was wondering now if you have time to all the panelists, if you could maybe provide us with just a very brief concluding point on what the next steps are and what we should look out for in the coming months. And whoever wants to start can go ahead.
Okay, I'm going to start. Oh, sorry.
Yeah. Go ahead.
No, please.
Oh, I think I just mentioned before September. I think September's coming up, the high-level meeting in pandemic prevention, preparedness, and response in the UN. I think things can get lost in Geneva. I think having all heads of state and government sitting in the UN General Assembly is an opportunity not to be missed. So I think we need to really drive towards that event to have the agreement adopted. So the PABS Annex adopted in May, doing everything we possibly can, whether that's setting up informal sessions, having those informal dialogues, cross-regional negotiating groups, just to have that agreement there. But in the meantime, I think we as civil society can help states to start build up the capacities needed to implement the agreement, to make sure that they can actually meet their obligations once they become parties, and really start advocating the treaty as an overall package, including PABS. Now, we're also mindful that the IHR is already in force. The amended IHR is already in force, so we can sort of tie those together. John, over to you.
Now I don't want to speak. I think that for me, yeah, what Alexandra said, but also in European terms, we have like two pieces of legislation that are going to be discussed in the European Parliament, like shortly, one on the Critical Medicines Act and the other one is biotech, that they have really like elements of importance for these discussions. Especially, I think that we are getting to a point that the position of the European Commission in these negotiations is starting to hurt other programs of the European Commission, especially like the Global Gateway and all the global health strategy. There are contradictions that will need to be solved at some point. I don't think that there's going to be a new mandate for the Commission. They will stick to what they have now, but I expect that some countries, and I think Spain, I think Belgium, I think maybe Ireland, are going to ask the European Commission to tone down the opposition and the really like that stance that it's really not being conducive to an agreement. I think it's going to be important also to see the World Health Assembly. What's the tone of the member states, in the sense that if we get to the World Health Assembly with PAPS signed, no one, or agreed, no one is going to miss the US. If we get to the WHA without PAPS and with the US having secured bilateral health security agreements with a number of countries, then it's going to be problematic. But as I said, I'm optimistic. I think that there is like a political will by a number of governments to pull this off. And I'm looking at Brazil, I'm looking at Indonesia, I'm looking at South Africa, I'm looking at Colombia. I think that that's something very interesting, that we are seeing new players really contributing. That's really positive. So I don't know, I think that we have more reasons to believe than to fear. So let's hope.
I agree. I'm also hopeful and optimistic because it is possible. What we will need, so in addition to what you both said, we need more bridge building efforts. Member states who are willing to convene, bring different regions together. We will need technical options. We will need to involve the industry to get reality checks. And on the global diplomatic stage, a level of diplomatic Olympics, because it's a very difficult geopolitical time. We need to be aware of all the risks, not just in the WHO during the World Health Assembly ahead of the adoption of the Paws Annex, but also in New York. So we have a lot of work ahead of us and everybody else who's keen to strengthen global health governance.
Yeah, if I may, I'll just add 2 points, but they're really aligned with what Jaume just said. Because I was thinking of the same things pretty much. On the one hand, internal developments in the EU when it comes to legislation. I was going to mention the Critical Medicines Act. It's going to be a key piece of legislation, and also to sort of see if the EU's internalization of this health security framing is aligned with global health priorities or not, or is it just a way to put the EU first, as we did during the pandemic? So I think it's going to be very important in that sense. And also looking on the other side of the pond, the United States just released the so-called America First global health strategy. If you do a quick Control F of that strategy, bilateralism is mentioned constantly, multilateralism is mentioned very sparsely, and sometimes just to say that the US will prioritize bilateralism over multilateralism as much as it can. The WHO is not mentioned whatsoever. And the concern here, as Jaume was saying, is that some of the deals that the US is already favoring, especially with African countries, are effectively structured to give priority to the US in accessing pathogen information, and that could have implications for PAPS and the WHO moving forward. So yeah, let's see how it all plays out.
Thanks very much for your concluding points and for these things to look forward to in the coming months. I'm aware that we're slightly over time, but I would like to give the floor to attendees. If you have a question for our panelists, please just raise your hand or type it in the chat, and we can direct it to our panelists to respond to. Okay, well, if there are no questions, then I just wanted to thank you all very much for participating in the webinar, especially to our panelists. And so a big thank you to you, Alexandra, Nina, Jaume, and Óscar. You provided us with some crucial insights into the challenges and opportunities coming up for global health governance, and given us some positives and some challenges as well to look at. So yeah, thanks very much for being here, and thanks very much to the attendees as well. So all the best and have a great rest of your day, and goodbye.
Thank
Thank
you.
you.
Thanks, everyone.